One, there is hardly any drug that doesn't have any side effects. And second, I very much agree with the previous speaker. Your patient doesn't need to sleep. There are circumstances where we would like to have our patients asleep, but in general, they don't need to sleep. And about the cost of dexmedetomidine in the cardiosurgical ICU at Columbia University, where I work, we spent more than $1 million on dexmedetomidine. So it's a lot of money, but very effective. For this, I have no conflicts of interest. Well, the first question is, if you think about hemodynamics, why do we use sedatives? Well, as I said, we sometimes want our patient in a condition where we can do stuff. Hemodynamically optimize the patient or do a procedure, and when you have a patient like this, that's a little bit complicated. So he was always like this in bed, and if we didn't sedate him, he was like this. So if you wanted to do something with this guy, you had to sedate him. But we know, and already quoted the Lancet study, even patients on high levels of PEEP do not necessarily need sedatives. We think they need sedatives, and then we give a lot because there's a lot of PEEP, so you need a lot of sedation, and then we get hypotension, and we more or less get ourselves into trouble. But even on ECMO, I mean, this guy, it's a little bit difficult to see, but this guy is biking in bed and emailing with his friends while he is on ECMO. And so even the most severe conditions do not really require sedation. So my first thing would be like, okay, really consider why you need sedatives, and then maybe think of some alternatives. This guy did very well with, oh, it's very dark. But he has a bottle of beer in his hand, and he was very quiet when he had beer. And so think about the drugs that you like to use. Now, the targets of sedation when we use sedation is that we have a calm, a cooperative, and comfortable patient. And having a calm patient is something that is totally opposite of what the system does when we're in trouble. Because what does the system, and was already alluded to a little bit in the dexmedetomidine, what does your system do when you're in trouble, in shock, in respiratory failure, in a lot of pain? You increase your sympathetic nervous system. What happens if you increase your sympathetic nervous system? Your blood pressure increases, your heart rate increases, your blood pressure increases. What happens if you decrease the sympathetic nervous system? Well, it's schematized in this simple graph. And so under normal circumstances, you are here on the curve, the relationship between flow and pressure. And with a significant decrease in flow, like for instance hemorrhage, very known in the ED department in trauma patient, with a very significant flow in a decrease in flow, you can have even a small increase in blood pressure. That's completely physiologic. That's your sympathetic nervous system. Now, that patient is not lying calm and telling you about the history of yesterday and the accident. I mean, they're in distress. And then you want to intubate, and you want to keep them calm, you want to limit the pain, and then you, of course, bring them from the increased sympathetic tone relationship between flow and pressure to the loss of sympathetic tone relationship between flow and pressure, and then you have no blood pressure anymore, with the same cardiac output in most cases. So what happens, and you frequently hear it from anesthesiologists, yeah, we had to induce the patient to get the tube in. He needed half a minute of CPR, not a lot, but we gave some epinephrine and then he came around. That's your loss of sympathetic tone. So that's a consequence of when you need your patient to be calm for whatever reason in a state of an activated sympathetic nervous system. Is that true? Because the previous slide was conceptual. This is a very simple slide of deep sedation in humans. And what they did is they increased propofol to either moderate or deep sedation, and they backed it up with the BIS measurement. And then they measured, the wrong one. Then they looked at heart rate and blood pressure, and as you can see in the propofol group, the heart rate goes up a little bit, and the blood pressure decreases with an increasing dose of propofol, or maybe with an increasing loss of sympathetic tone. Maybe it's not the real vasodilation of propofol that induces your hypotension, but maybe it's the loss of sympathetic tone. Well, they measured, let's say, the effect of sympathetic tone over here, sympathetic nerve activity, that's on the arm. And as you can see on the spikes, when with an increasing dose of propofol, here are a few spikes, but at deep sedation there is no spikes anymore. The sympathetic nervous system is down. And this immediately translates in a significant decrease in your norepinephrine levels that are, of course, increased by stress and sympathetic nervous system activation. Now, there is loss of vascular resistance, so there is a dose-dependent effect on, let's say, vasodilation that is related to the effect on blood pressure, but there is a huge effect on the sympathetic tone. If you then compare the effects of, for instance, propofol or a benzodiazepine, so a different way of getting to the same goal, your calm and sedated patients, they looked at the propofol and midazolam, they looked at heart rate and other indicators of the circulation, and as you can see, the blood pressure decreased with propofol, but also decreased with midazolam. And when they looked at the, and this is a little bit complicated, at the heart rate variability, we don't have very good assessment of sympathetic nervous system in our patients, but the heart rate variability is the difference between heartbeat number 1, heartbeat number 2, heartbeat number 3. So even with a heartbeat that is consistent at 90, because the monitor consistently tells you that the heart rate is 90, there is variability in milliseconds in the RR interval that is not translated in the heartbeats per minute that you see on your monitor. Now, if you do a translation of these intervals, a Fourier analysis, you have a low frequency signal and a high frequency signal, and the balance between the two tells you something about sympathetic nervous system and parasympathetic nervous system. There's a lot of debate about this, but this is basically the only practical thing that we have in a stable patient. So if you induce something else, so you increase propofol and immediately increase the norepinephrine, then you're lost, of course. But in specific one interventions, so you do one thing, measure before and after, and then nothing changes in between, it's a relatively good marker of the effect on your parasympathetic and your sympathetic system. Now, they measured all of this in these patients, and what they found, the basic conclusion is that propofol enhances dominance of parasympathetic. And so you could see it as it's always said, you have a brake and you have a gas pedal. If you ever driven a Formula One car, you know that you cannot drive it by letting go of the brake and letting go of the gas. That will end up dramatically. So you have full gas and you throttle. You throttle and you brake. That's what you do. And so what this does, it enhances your parasympathetic nervous system, even though there is activated sympathetic nervous system. And that's why you have an overly active parasympathetic results in a total negative effect, and so a decrease in blood pressure. And midazolam enhances sympathetic activity. So you have a loss of, you have a somewhat decrease in blood pressure, but overall, it enhances the sympathetic effect on the nervous system. Now, ultimately, we do this stuff to reach something. For instance, intubation. Now, intubation is frequently done because there is maybe a risk of aspiration, or you have increased metabolic demand. a patient who is breathing 40 times a minute in septic shock, a very easy intervention to restore balance between oxygen delivery and oxygen demand is sedation and intubation. And then you pay the price of the hypotension, because the change in metabolic demand is more important at that moment than the, let's say, increase in norepinephrine. And that's, for instance, they study by the group from Glenn and Anders, where they showed that indeed, if you sedate a patient that is heavily breathing, working hard, you sedate the patient, you optimize the balance between oxygen demand and oxygen supply. And that can be a very valuable goal at that point in time. And so, although you have the effect on the blood pressure, there's a significant decrease in blood pressure to levels that are even below the guidelines, 57.5 decrease in blood pressure. The overall effect is that you have a better oxygenation. Your SVO2 or your SCVO2, whatever you measure, and this they used SVO2, SCVO2, it improves, and so the overall circulation benefits from the negative effect from your sedative. So it's a plus and minus. It was already discussed a little bit, the use of dexmedetomidine, medetomidine or propofol in neurocritical care patients. As the previous speaker on Dex already told you, it has side effects, and the side effects relate to blood pressure. You can have decreases in blood pressure, and as you can see in this matched cohort, the incidence of bradycardia is not that great. I mean, it's about 7 to 10%, and not different. There is somewhat more hypotension, and somewhat more of a combination of bradycardia and hypotension in the propofol group, but it's not really significant. But with a lot of interventions, you can still maintain the patient at the what you think is the required hemodynamic situation. And as you can see, and this is the matched cohort, in both cases it was about in 10% of the patient that they had to add norepinephrine to the fluids that were not, let's say, sufficient enough to maintain blood pressure. That can also be related to the complete misinterpretation of the concept between the relationship between flow and pressure. We frequently think that if you increase cardiac output, your blood pressure will go up, and so maybe none of these fluid resuscitations were necessary, and you could just increase your norepinephrine, but that's a totally different discussion. But you have significant hemodynamic effects, and especially, I'm not very concerned about hypotension, but in neurocritical care, I get worried when you have, let's say, a bolus of something and the blood pressure drops. That's not very good. And so in 30% of your patients, you have these side effects that you don't want. Now, we were interested in the hemodynamics of dexmedetomidine because it has this, let's say, suppression of your sympathetic nervous system that can have beneficial effects as well in more severe conditions, like severe septic shock. And so we did an animal model. And the animal model was severe septic shock with endotoxin in sheep. And we instrumented the animal so that we could also measure the regional circulation. And in this case, we were especially interested in the gut circulation and the liver circulation. And what we did is we compared it to esmolol. That's a different topic. But we used quite high doses of dexmedetomidine, 0.5 for an hour after the induction of septic shock, and 1 in the final hour of septic shock. And the thought was that you have an alpha blocking agent, and so it should reduce the sympathetic stress in these animals. And we were interested also in lactate clearance, but we were also interested in what's the effect on blood pressure and regional circulation when you use a rather high dose of dexmedetomidine in these very sick animals. At the end of the experiment, the average animal had a lactate of 9 to 10 and a lot of norepinephrine, as you can see in the next slides, to keep them a little bit stable. So this is a severe septic shock model. Well, what we found is it has no effect on cardiac output, and it didn't affect total hepatic blood flow. But it had a significant effect on blood pressure. No significant effect on blood pressure. So this is the baseline induction of septic shock, first hour of dexmedetomidine, and the second hour. And as you can see, there was no real effect on blood pressure, nothing much. So not cardiac output, not blood pressure, not regional blood flow. But there was a significant effect on the norepinephrine requirements. And as you can see, I mean, it's only a few sheep, so the results were not significant. But if you compare it to the end of septic shock, so resuscitated, fluid resuscitated, and then the first hour, you almost need twice the amount of norepinephrine. But no effect on regional circulation, no effect on delta PCO2, no effect on mitochondrial respiration. There was no effect at all on indices where we would think that you would induce, let's say, tissue hypoxia. Was there a positive effect? Well, that's what we were looking for. The effect on epinephrine levels and lactate levels. And as you can see, there was a significant reduction in epinephrine levels. So we had a significant reduction in the sympathetic nervous system activation that we counteracted with norepinephrine, but still we had a significantly lower lactate levels. As you can see, the control group at 9 and at the end of the experiment, and 8 after 1 hour of treatment, and lactate was almost 50% at this time and 30% lower at this time. So the message here is more like, okay, if you have doubts about sympathetic nervous system and you want to use norepinephrine and you want to use dexmedetomidine in your shock patient and you have a fluid resuscitated patient, there is no reason to be worried about increasing norepinephrine and then reducing gut circulation or liver perfusion. That's not what we found in these patients, in these sheep. And so if you think there's an indication for DEX and there is a decrease in blood pressure, have no worries to increase your norepinephrine. And I don't think you should give fluids, but that's a different discussion. Another thing, and that's one of the more interesting studies and not really easy to understand, is when you have septic shock and you give dexmedetomidine, that the responsiveness of your adrenal receptors improves. And so this is a study where they induced septic shock. This is baseline, and this is titration curve of norepinephrine to the effect on pressure, so delta pressure. And this is the normal curve. And of course, when you induce septic shock, you will have less responsiveness, so you need more norepinephrine, and you cannot even get the same effect. But when you give the dexmedetomidine, you restore the response to norepinephrine completely to normal. And this is an interesting effect of dexmedetomidine that you could use maybe in clinical practice. So to summarize, you can make graphs or tables like this, where you summarize the effect of all the drugs that we have on all the receptors that we have. But I think that you have to keep in mind that this is individually based. This is completely different in one patient to the other patient, and I think there is a significant dose effect. The more you use, the more side effects you will have. So in conclusion, I think the effect is dose dependent. Be especially careful in your stressed patient when you use whatever sedative. And dexmedetomidine has very interesting hemodynamic effects in sepsis that do not immediately translate to clinical practice, but are interesting for further research. Thank you very much.